Hello, I'm Dr. Daniel Griffin.
And I'm Dixon DePommier.
And today we're going to be discussing HIV, AIDS, the human immunodeficiency virus, and acquired immunodeficiency syndrome.
Wow, that's a big topic.
Now, I don't know if we've talked about this much before, but I actually was living in New York City, in Greenwich Village, a teenager with my parents in the epicenter of the epidemic when it hit New York City.
I'll be darned.
So this has always been, I think, a challenge that's always been sort of near to me personally. My mother actually sat on a group in our community, and a lot of them were activists from ACT UP and some of the other organizations trying to get funding and trying to get things done for people with this infection.
Back in the 1980s?
It was actually the early 1980s. I was living in Greenwich Village when we first started to see the epidemic hit.
Right.
We didn't know what was causing it at the time. We just knew that our neighborhood was being devastated. And a lot of the young individuals living in that area were dying of this mysterious disease,
Exactly.
which later we identified a virus to be causing this.
Interesting.
The human immunodeficiency virus. Most of it type 1. There is a minority type 2 that we still see coming out of West Africa. But most of it worldwide is type 1. And it's really, times have really changed since the early 1980s. In certain ways they've changed, in certain ways they haven't. So today we're going to be talking a little bit about the current state of the epidemic, but really a focus on clinical, on what we can do about it. So first, the magnitude of the problem. Over 35 million people infected worldwide with HIV. In the U.S., over 1 million. So this is not something that spares, the developed world. In the U.S., we see 50,000 new diagnoses per year.
Really?
Worldwide, we see over 1 million. So when people talk about the end of the epidemic, we're really not quite there yet. We're living in the midst of a huge epidemic. But what has changed is our ability to do something about this. A couple things we'll talk about, just background about what this is. A virus. This is a viral disease. It affects our immune cells. It actually destroys our T cells, the CD4 positive helper T cells. And as a consequence, if this virus is not controlled, the immune system falters, and the presentation is with all kinds of what we call opportunistic infections.
Exactly.
And in different areas of the world, different opportunistic infections.
Right.
So let's talk about the clinical disease. We're going to talk a little bit about acute presentation, and then we're going to talk about chronic disease. So what about acute presentation of HIV? I don't know if this is something that you're familiar with at all?
Well, I'm a co-host on another show called This Week in Virology. So we've actually had a lot of discussion about HIV from other people, not myself, because I myself am not a virologist. So why am I on that show? Because I was asked to do it, and I haven't regretted any of the times that we've had this podcast going. So we've heard a lot about HIV, and we know it's a retrovirus, right?
It is a retrovirus.
And by that we mean... No, I'm waiting for you to fill in that blank.
Oh, this is what I always enjoy when occasionally I listen to your podcast too. So it is a virus whose genetic material is RNA.
Yes.
And it's actually reverse transcribed into DNA.
Exactly.
And then the DNA is integrated into the cells permanently.
Yeah, that's...
And so it's
a crazy strategy.
Yeah, it's crazy successful strategy, as we're seeing in this case. So in the acute presentation, and I wrote a paper about this recently, where there was a school teacher.
Yes.
She was recently divorced or separated. She actually wasn't married, but separated from her partner of several years. She had one new sexual partner who was actually a friend. She'd been friends with this individual for years. Period of time after they were physically intimate, she ended up going to the emergency room with fever, headache, swollen lymph nodes, rash.
Wow.
She was told, it's just a virus. They were right. except for the just parts.
Exactly.
And this was actually an acute presentation of HIV.
I'll be darned.
So acute presentation of HIV, it can present with fever, swollen lymph nodes, feeling tired, a rash, a pharyngitis, an inflammation of the throat. So like many other, almost we'll call them mono-like illnesses.
But how long after exposure did this occur?
So it's limited. It's there's a limited peak of you're exposed.
Right.
You initially acquire the virus. You don't have symptoms until the virus starts to replicate to a certain point.
Sure.
So there is the timing and association. Then you come in with your symptoms, and the older tests, there was a window period when you might miss the diagnosis.
Huh.
And that was actually one of the things that happened. She came back again during this window period.
Yep.
The virus was starting to replicate, but she was yet to become positive by some of the older testing.
Gotcha.
And one of the things, and this is a nice sort of jump right in many parts of the world, the rapid testing is becoming available.
Nice.
Because I think fortunately people have seen this as this is the world's problem.
Exactly.
It's horrible that all these people are suffering.
Right.
That doesn't always prompt action, but it's been embraced as this is a problem that the world wants to address, and there's been quite a bit of money and resources put targeting the HIV epidemic.
That's right.
And in a lot of areas, we now have the ability to make early diagnosis. We have the ability to screen people between the period of the acute disease versus what we'll talk about as our chronic disease.
Right.
So let's talk about chronic disease. This is maybe something a lot of our listeners might be more familiar with. There was a name for HIV in Africa. I don't know if you're familiar with the Slim's disease.
Slim's disease.
And this was based upon
wasting disease. Yes.
And that's why it got the nickname of Slim's disease. Is people start to waste away. Weight loss can be a significant problem with chronic, uncontrolled HIV infection. So weight loss is a big thing. Secondary infections.
Yeah. Lots of them.
The big one, tuberculosis, which we talk about in one of our other lectures. Even early on after HIV infection, we see a significant increase in activation in active tuberculosis.
Right.
We might have thrush. That's often early during acute or definitely during advanced untreated disease, which is a fungal infection of the mouth, of the mucus, candida of the mouth, uncontrolled. Right. And then there's a whole list of other pathogens that jump in, but early on we may just see more bacterial infections.
Sure.
So a lot of times people will come to medical attention late.
Exactly. Or for the wrong reason. That is to say, the clinician makes a diagnosis based on the secondary infection rather than the underlying cause of the activation. I recall an epidemic in France where they had lots of encephalitis due to reactivation of toxoplasmosis.
Okay.
And it lies dormant for years. HIV seems to suppress the immune response that keeps toxoplasma contained. Mm-hmm. And then as a result, it's an epidemic of toxoplasma. Wait a minute, it's not an epidemic of toxoplasma. Everybody has toxoplasma in France.
Yeah.
A lot of people.
80% is the estimate.
80%. It's something that causes it to activate where the immune system ordinarily would keep it in check. So it's a horrible disease everywhere you look.
Yeah, one of the early epidemics that made us recognize HIV was an epidemic of pneumocystis.
I was going to say that too.
So we saw a lot of pneumocystis cases. It wasn't suddenly more common,
right?
But the immune suppression was causing us to see more cases.
And that's another fungal infection also. We thought it was a protozoan.
Cryptococcus.
Oh my goodness.
They say that's the number one presenting opportunistic infection in sub-Saharan Africa.
I'll be darned.
I didn't believe it when I first heard that, but when you go, and yes, it is actually quite common.
Wow.
But unfortunately, it relates to the fact that a lot of the diagnoses are being made late, where hopefully you would diagnose this through screening, preventing the decimation of the immune system.
Exactly.
So let's talk a little bit about parameters in HIV. So we have the virus, and we can measure levels of the virus. And we have the immune system and the CD4 T cells, and we can measure levels of the CD4 T cells. So when we make the initial diagnosis, which we are often doing through an antibody test, which we can also confirm by actually measuring active virus, the two parameters that are going to help guide treatment are going to be viral loads, the level of the virus in the blood, and the level of our CD4 T cells.
Which is their cell of choice to infect.
Exactly. So the virus, I think, is pretty easy. We would like to see it undetectable.
Absolutely.
And a lot of medicines, we're going to talk about that, can get us there. Our CD4 T cell level is going to tell us really what we need to worry about as far as opportunistic infections.
Right.
We'll say roughly, to give a round number, roughly normal would be about 1,000. Okay. Above 500, we don't see much noticeable. Below 200 is where we start to see a significant increase in opportunistic infections. And as we get down at 100 and then particularly 50, the immune disturbance becomes more profound. So as far as monitoring, in a lot of parts of the world, you think resources are limited. This is pretty high technology testing. But because of the global commitment to the HIV epidemic, in a lot of places you'll have the ability to do viral load testing and CD4 or T cell levels.
Right.
These are usually done by government organizations or non-government organizations. So a lot of our small clinics will be referring to HIV treatment centers.
So I have a question related to that, and that is, one might be tempted to say, as long as you've made the diagnosis of infection with HIV, why don't you just start treating? Why do you have to measure the level of T cells? Because wherever stage of infection you're at, it's not good, because if you delay treatment, of course, your T cells will get lower and lower. Why don't you just start treatment the moment the diagnosis is made?
So we do.
Oh.
And that was no, and that's an excellent question.
I'm not withdrawing my question.
Because that is a change in the paradigm.
Got it.
There used to be an idea, and there was a certain truth to it, because there was a certain truth to it, that there was a significant toxicity to the early medications. And so you were balancing toxicity of the early medicines, the commitment to taking that medication, with the benefit that those medications might provide.
Got it.
So in resource-rich areas, the current standard of care is to treat everybody.
Right.
Doesn't matter what the viral load, doesn't matter what the CD4 T cell count is, you treat everyone. In other parts of the world, and this is their balancing resources, they pick different levels of T cells at which they might start therapy. It might be 500, it might be 200, but everyone with, if resources are adequate, is moving towards a universal treatment.
Yeah, because eventually they'll all get lower if you don't treat.
That's one reason. The other is the concept which has been introduced of treatment as prevention. And there's this concept of what we call the 90-90-90 rule. And in many areas, and I'm going to use Botswana as an example, and I'm going to actually say HIV treatment in Botswana is better than HIV treatment in the United States.
Really?
And I'm going to explain why I say that. So the commitment in Botswana is to make sure that 90% of the people with HIV are aware of the diagnosis, are diagnosed that they have HIV.
Okay.
In the United States, that number is much lower. But in Botswana, they claim that they're reaching a 90% success rate with diagnosing people that have HIV with the disease. The next level is now you have your patients diagnosed with HIV. The commitment is 90% of them are on treatment.
Got it.
Not quite getting there in most parts of the United States. And then the last is 90% of those people on treatment, the virus is completely suppressed.
So there's no transmission then?
That's the goal. If you have no virus in your blood,
how can you transmit it then?
Yeah.
So where is it?
So there can be virus reservoirs in memory T cells.
Right.
There can be a certain amount of HIV that might be in semen or other sexual fluids.
Got it.
But one of the nice things is with the concept of treatment as prevention, It's been shown now with millions of individuals that if the viral load is undetectable, you're stopping transmission.
So these therapies, do they only work if the virus is replicating? Is that what the problem is? Because the ones in, let's say, memory cells are dormant? I've heard it spoken like that. I don't know if that's exactly true.
Yeah, so this, interesting enough, the paradigm of HIV reminds one maybe of the paradigm of hypertension or diabetes, is that one of the things that we're left with is we don't have a cure.
Right.
It's been, there's one individual and it was an outlier. But in general, we're not offering patients cure of HIV. We're offering them lifelong treatment.
Right.
Very effective lifelong treatment. And just some principles, and this is an overview because I'm going to say in general, most of your HIV care will be done by individuals experienced or specializing in this. In many places, it will be driven by protocols. There'll be a standard in-country cocktail as a first line. There'll be a standard in-country cocktail as second line. And those standard cocktails will usually involve, we'll go through, as we do in our book, the different classes. So one is a reverse transcriptase, that's an RNA to DNA enzyme, a reverse transcriptase nucleoside inhibitor. So if we think of our DNA and RNA, we'll think DNA, A's and C's and G's and T's, right? They all get strung together. Well, when we're making our DNA, if we modify those slightly so they chain terminate, so we have chain terminating medicines that are sort of dummy A's, C's, G's, and T's. Those are our nucleoside or nucleotide-based reverse transcriptase inhibitors. Right. So in a lot of cocktails, there'll be two of those plus a third agent. And that third agent may be a direct inhibitor of reverse transcriptase, what we call a non-nucleoside reverse transcriptase inhibitor. Second line therapies, that third agent may often be a protease inhibitor, which is another enzyme important in the sort of splitting of the protein in HIV. And then in some areas, Botswana, for instance, is introducing integrase inhibitors, an inhibitor that's blocking the integration of the DNA into the host cell DNA.
Cool. These are all specific for the virus and not for the host.
So they're as specific as can be for the host. They tend to be protocol driven. So you go to whatever country and you want to find out what are the protocols here. What's our first line cocktail? What's our second line cocktail? There may be salvage options as well. As much as possible, we're trying to get these to be single pills once a day. Right. In addition to treatment, we have two other things that I want to make sure we touch on before we leave here. Post-exposure prophylaxis and pre-exposure prophylaxis. And so post-exposure prophylaxis, sort of in the name, you've had a high-risk exposure.
Right.
And again, there's a cocktail, 3 drugs that you might use to pretty significantly reduce your chance of acquiring HIV. Start within 48 hours. Take your 3 drugs, take them for 28 days. If possible, you want to know that the HIV you've been exposed to is not resistant to one of those drugs. Sometimes it gets a little more complicated, but the standard there is going to be a 2 nucleoside combination and then a third agent, actually usually an integrase inhibitor in many settings. Pre-exposure prophylaxis is going to be 2 of the nucleotide reverse transcriptase inhibitors, usually in a combination pill. Again, taken for some people lifelong because they're potentially going to be exposed and you want to have a blood level should the exposure occur.
So how expensive are these drugs?
So that's a fantastic question. In the United States, some of these medications, if you're paying for them, may be over $2,000 US a month.
A month?
A month. So very expensive. In a lot of parts of the world, these medicines are provided for no cost to the patients.
Of course. I mean, because the expense of taking care of a person suffering from AIDS is astronomical. I mean, it requires a multiple team of healthcare delivery systems that far exceeds the price of these drugs. Why don't we get on board, so to speak, and
no, I think
give the drug away, basically, because
Yeah.
you're going to save so much in healthcare insurance.
Yeah. No, and there's
Is
a
that
whole,
true? I mean, I'm not making this up. I don't.
Well,
think.
I think there's several reasons why you want to provide the medicines for free, for I'll say no cost to the individuals who are affected.
I mean, a drug company should be compensated somehow for the effort of providing the drug, but this is a ridiculous price difference for the same drugs, right?
Same drugs.
That's absurd.
Same drugs.
That's absurd.
Same drugs. All right. Well.
Oh wait, same virus too, right?
Same drug, same virus.
Oh my God.
All right. Well, this is, I'll be honest, this is a very brief introduction to HIV care. But hopefully this lecture is being used to sort of get the conversation started.
Right.
Because each country is going to have individual regimens. So what you're going to do is you're going to go to that country and you're going to customize how you're approaching this. You're going to want to find out what are the resources in this area. And then you're gonna work with that context.
Wow.
All right. Well, thank you for joining us today
Yeah.
for a topic very near and dear to my heart.
See you again soon.